Hello, my name is Jacqueline Bernard, and I'm the Predictive Analytics and Application Development Lead at Texas Children's Hospital. Today, I'm going to talk a little bit about the predictive model we developed for unplanned pediatric readmissions. I'm going to go ahead and share my screen. Like many hospitals, we have a quality goal around reducing readmissions. Currently, about 5.3% of patients at Texas Children's are readmitted to the hospital within 15 days of discharge, when we didn't know they were coming back. And we assume that at least some of these readmissions are preventable. Texas Children's is part of the Solutions for Patient Safety Collaborative. As such, we help to develop a readmissions bundle that includes the elements listed on this slide. The idea is that performing these interventions, creating a comprehensive discharge plan that includes an accurate medication list and instructions about who to call with questions, for example, are actions that set patients up for success and help to prevent readmissions. In practice, scheduling follow-up appointments for patients before they leave the hospital and making follow-up phone calls within 72 hours of discharge are particularly resource-intensive actions. And we just don't have the capacity to do these for every patient who comes through our doors. This problem is not unique to us. To help solve this scarce resources problem, adult medicine has long used readmission risk scores to help stratify patients and point resources to the patients who need them the most. We wanted to do the same thing. Unfortunately, the risk models that were easily available to us were not suitable for pediatrics. We were going to have to develop our own model. From an analytics team perspective, we began this project with consultants and then transitioned it to data architects and an application specialist from Texas Children's. Subject matter experts were pulled from existing readmissions quality improvement work groups around the organization and included representation from nursing, care coordination, complex care, and quality. The model itself is designed to predict 15-day unplanned readmissions prior to patient discharge. And I want to unpack that a little bit. Unplanned readmissions means that we exclude elective admissions, as well as those that have an expected admission date attached. Things like chemotherapy or scheduled surgeries, for example. We're not trying to predict those. And importantly, we want these predictions to be available before a patient is discharged, so that we can do interventions while they're still with us in the hospital. That means that all data consumed by the model needs to be there well before the moment of discharge. So no billing information and no discharge medications whose orders won't be placed until right before a patient goes home. Texas Children's cares for adult patients in our pavilion for women, but we wanted to focus the model on our pediatric population. And finally, given the trade-off between precision and recall, needing to be really sure about a patient before we intervened versus trying to catch as many true readmissions in our predictive net as possible, we chose the latter. Our goal is to prevent as many readmissions as possible, so we're okay with some false positives as long as the total number of flagged patients is manageable. We used over 3 years worth of historical admissions data to develop the model, and the model has 44 features, which fall into 5 categories: admission information, demographics, complexity, diagnoses, and procedures and medications. Now, I always tell my clinical and operational partners that we are not chasing magic metrics as we develop models, that a good model is one that is useful to us. And that is true, and we will talk about that in a minute. But I do secretly have one magic metric, and that is area under the curve. Area under the curve measures a model's ability to discriminate between positive and negative cases. And generically, 0.7 is considered good and 0.8 very good. The publicly available models we looked at, designed for adult populations, when you looked at the area under the curve for pediatric populations, they tended to range from about 0.5 to 0.65. That's hardly better than a coin toss. Our model, on the other hand, has an area under the curve of 0.78, which we consider very good. In terms of non-magic metrics, we're primarily focused on action and recall, because taken together, That indicates usefulness. At a threshold of 5%, if we consider patients with at least a 5% chance of being readmitted as high risk, we flag 20% of our patients as requiring that highest level of intervention, of receiving all of the elements in our readmissions bundle. And within that 20%, we're catching 60% of true readmissions, the patients who need those interventions the most. We consider this a manageable and useful level of prediction. If you'd like to learn more about our readmissions model or how we're implementing it in a patient care setting, I would love to chat with you during the live Q&A.